This is Warren Vanderhill with the Center for Middletown Studies project on Muncie service providers, and today it's my privilege to be speaking with Bryan Ayars, the CEO of Open Door Health Services. The date is November 9, 2018. I want to begin by thanking you for agreeing to participate in our project. I'd like to begin with having you tell us a little bit about your background. I call this, as a historian, the Wayback Machine. Just go back there someplace in the deep recesses of your past and where you grew up and where you went to school and where you were, what you were doing before you came to Muncie.
So the way back is way back when I was 15, I joined the local volunteer ambulance service.
Okay.
That was my introduction to healthcare. Stayed in that for a good long time, became an EMT, then a paramedic, worked in hospitals. It was clear then to me that this health system was a little odd. What we saw in the ER and what we saw in the pre-hospital setting was a whole different exposure to what I thought life looked like. I worked in a few hospitals, went into management when I decided I'd had enough bad managers and thought I could do better. Mm-hmm. I'm not sure that that's true, but I try. So went to school. I grew up in Pennsylvania, Lancaster County, finished my education in Bowling Green at Western Kentucky University, and ran a small hospital. I've worked for state government overseeing their primary care programs, did some healthcare consulting, and this is the second health center I've been part of.
I noticed in reading your bio, it referred to, were you in Western Massachusetts for a while?
Correct.
Okay, where were you?
Western Massachusetts is often called the Berkshires, which is the county.
Right.
Fairly rural, big disconnect between affluent and hardworking poor. Mm-hmm. And it's a vacation area for a lot of people out of New York.
Yeah, right.
Beautiful area, has a lot of the same challenges that Muncie and Delaware County have.
What's the just to get this on the record, the history as you observed it of the industrialization of that area? What happened to Western Massachusetts?
So Western Massachusetts, like the majority of rural New England, which is anything off the coast, they were built on mill towns. And the mills have been closing for generations. Mm-hmm. And similar to the Midwest, they were one company or one industry towns, and well-paying, very secure jobs. People would have jobs right out of high school. Their dad worked there, their granddad worked there, and as the mills closed, there was nothing to replace them. And certainly, if anything did, it was for lower pay and worse benefits.
Well, and just in your recent past, has anything come into those areas to take the place of those factories?
In some rural areas, state and federal prisons were tried. That has limited success, but the pay is pretty good. It depends on the community. One community in Western Massachusetts happened to be on a main drag, and they built up the downtown, and it's flourishing. Other communities just continue to struggle, not unlike a lot of Midwest towns.
Mm-hmm. But there, I guess I'd call, you'd have a great deal of what I guess can only be called rural poverty.
It is absolutely rural poverty.
Yeah.
You can equate it to Appalachia.
Mm-hmm. Yeah, that's what I thought, yeah. Well, what attracted you to this position?
Good organization, interesting community. Through the family, I've got some exposure to Indiana, so it was not a foreign area to come to.
Yeah, talk a little bit more about that.
It's just, compared to Western Massachusetts, it's flat. I spent 7 years in Kentucky, so it's not too far removed from this area. Mm-hmm. And I like a challenge. And there were some challenges here to be met.
But you mentioned your family connections. I wanted to get that on the record, too, your Indiana connections.
So my mom grew up in Wabash. I still have a lot of family in Wabash. I have a sister who lives in LaPorte with her family, and I've got cousins and nieces and nephews in various areas around the state.
Yeah. Did you know much about Muncie before you came here?
I didn't know a thing about Muncie.
Okay.
I'd heard about Ball State, and that was it.
Okay. So all this stuff about the nation's Middletown is totally foreign to you.
That was, I learned that in my research before the job.
Oh, okay.
Yeah.
Okay. Again, this may be an unfair question because you haven't been here that long, so you can use any points of contrast you wish, whether it's annual reports or what you discovered when you got here. But my second question is, how have the services that your organization offers changed over the past? What I've been using is the rubric of the last 20 years or so.
So when the organization started, it was basically a human services organization. Started to provide some health services, and then, as I understand it, reverted back to largely non-healthcare human and support services. We're now largely a health organization. One of the big changes of the last couple of years is providing more and more behavioral health and substance abuse. The area has its challenges with substance abuse, as do many, many communities, and there's a necessity to provide the service.
Okay.
So we tend to provide whatever services the community needs if nobody else is doing it.
So you're really responding to the problems that
Absolutely.
exist in the community,
Yep.
and that's where you get into the drug epidemic.
Sure. And I mean, the drug epidemic, and it's not just opioids and it's not just meth, it's drug use and abuse, affects everything: healthcare, families, jobs, availability of jobs. It's an economic issue as much as it is a health issue.
Okay.
And any other, it's just related to everything.
So based on that, then how has the relationship of what Open Door provides, how has the relationship with your clients changed? Or maybe the clients have changed, or they're different people?
90+% of our patients live at or below 200% of the federal poverty level.
Okay.
Many are still without health insurance. Many are on a Medicare or a Medicaid product, and not every physician or provider can afford to take those.
Okay.
We do. We'll take whoever needs our services, regardless of their insurance status or ability to pay.
Okay. Well, you're the person I can ask because you have expertise in this area. This is my own naivete. How does Medicaid actually work when it comes to your clients? I mean, take me through this with, I'm a client, I come here, I'm on Medicaid. How does that whole process work?
Same as it does as any other insurance. We will bill the insurance company, in this case, Medicaid, the state, or one of their contracted companies, Anthem, for example, and they pay us what they feel is due.
Okay.
It's usually through an agreement ahead of time.
Yeah, I mean, the reason I bring it up is you hear all these debates that are raging about Obamacare this and Obamacare that, and states that have expanded Medicaid and states that haven't. And Indiana seems to have done something that isn't really one or the other. They've done something that's kind of unique to Indiana. And I wonder how that plays out.
Indiana has what's called HIP, or HIP 2.0 now,
right.
which is just, it's a variation on the theme of Medicaid.
Okay.
Every state's allowed to do things pretty much their own way. Rule of thumb, it's a 50-50 split in expenses. 50% of the cost of Medicaid goes to the state, 50% is federal. The states are allowed the some autonomy of tailoring the services they provide, the reimbursements they provide, to what they deem is essential.
Okay.
What the Obamacare Affordable Care Act mandated was, if you have insurance, or if you're offering insurance, you have to offer these preventive services. The emphasis is on preventive care.
Right.
That's cheaper than the end of life and chronic care.
Where does this other raging debate piece, I guess, because I think Indiana has this, but I'm not sure, the work requirement, where does that come in with people who are on Medicaid?
There are many, many ways to define work. The state has defined that. The challenge will come when the economy is at its worst and there are more and more people dependent on Medicaid. There will be fewer and fewer jobs to meet the requirement, which is going to be counterintuitive to many people, and it'll create its own problems.
Right.
A lot of individuals that are on Medicaid or a Medicaid product, single parents, they can't afford to go work or volunteer because they need to pay for daycare. Right. Daycare is hugely expensive, and it's getting more difficult to get a qualified daycare provider. Okay. So it's I understand the instinct, but it's not. I don't think it's really workable.
Is there a work requirement in Indiana right now?
It will start in January.
Okay, but as you say, how do you define work? I mean, is that so many hours?
So the state has defined, and there are different federal and state programs, so there are some variations on what counts. But if you're going to school for a certain number of classes, if you're volunteering for a certain number of hours, or if you're working for a certain number of hours per week,
Okay.
you can stay on Medicaid.
Okay.
Some of the challenges are, how do you verify all that, and who's responsible to do that?
That was my question. Who logs it? The individual or you or?
The individual and the state, or the state's contracted agencies, are responsible for that. We are not at this point. I'm
Okay.
afraid eventually any provider will be required to play nanny,
Okay.
and that just isn't going to work well.
Yeah. So that person then would have to come to you and be on the Medicaid rolls or lists or something like that?
We have a list through the internet, and through this, computer centers. We know who's on Medicaid and who's not.
Okay.
The challenge for the state is, if you're on Medicaid, how do you prove that you're actually volunteering or working someplace?
Oh, okay.
If you're volunteering, you're not getting a W-2. So how do you go about doing that? And who's
Yeah.
responsible to make those accurate?
Well, I don't mean to really
attestations.
push this that far, but when you say you can volunteer to do what? I mean, what kinds of volunteer things would be?
You could volunteer
eligible?
you could volunteer at the school. You could volunteer for us in some
Right.
role. You could volunteer at the Muncie Mission.
Okay.
Take your pick. If it's an organization that wants volunteers and essentially qualifies, and the qualifications are rather broad,
Okay.
then it counts. For a lot of the individuals that are required to do this, it's a time commitment, and for many it's a transportation issue that they don't have
Right.
either of.
Okay. But the person then, the client,
Mm-hmm.
would have to have some way of logging this to present
Correct.
as evidence
Yep.
to somebody
Right.
so they can stay on the Medicaid rolls.
Yep.
Okay. Let me go back a step. How does someone now get on the Medicaid rolls?
You can do it yourself. We have, I think, 8 or 9 full-time individuals that will help people find insurance they qualify for. It's all about qualifying based on your household income and
Okay.
size.
Okay. So someone presents you with the evidence of what they have.
We will help them get enrolled.
Okay. Now, go back to your client base. Of the people who are your clients,
Mhm.
the larger percentage of them are on some Medicaid form?
The largest percentage are on Medicaid or a Medicaid product.
Right. What is Medicaid product?
So
mean?
managed care organizations or
Okay.
managed care entities, they contract with Medicaid to provide the service.
Okay.
So it's kind of a middleman.
Yeah.
They have different incentives. It's a for-profit
Oh, okay.
middleman.
Okay. What are the main goals of your organization?
Our main goal is to improve the lives of the patients we serve.
Okay.
And through that, we hope to improve the community as well. So it's not just healthcare.
Well, talk a bit more about that. I mean, so someone comes in the door and talk a bit about the array of services that might be available to someone.
So if somebody comes in the door, we have medical services that go from prenatal to death. We do deliveries. We have behavioral health. We offer dental services. We offer translation. Our family planning, WIC program. We have insurance enrollment, people I already mentioned. We have several sites here in Muncie. We have an urgent care here in Muncie, and we have a mobile unit that goes to most of the schools, but can
Yeah.
also go out into the community to provide the services.
Now, again, using this as a point in time, 20 years ago, you wouldn't have had this array of services?
20 years ago, we might have had primary care and different types of primary care, pediatrics
Yeah.
and family medicine.
Okay.
Probably not as much internal medicine. Now we have all three.
Mm-hmm.
Dental came to be more common maybe 10, 15 years ago because there's a huge need.
Yeah.
And I think we're able to, with great comfort, say there's a direct correlation between your oral health and your health of the body.
Yeah.
And of course, in mental health or behavioral health, that's been kind of cut off
Yeah.
through the way insurances are set up. One's dependent upon the other. The health of one
Okay.
is dependent upon the other.
This is a kind of societal question. What do you think are the root causes of the challenges that you're dealing with here?
Education, job opportunity, and there's a level of an inferiority complex in the community that needs to be overcome.
Okay. Expand on that.
So, for example, when I moved into the community a little more than 2 years ago, one of the most common questions I was asked was, why would you move here?
Okay.
And I've spoken with other new people in town, and they've met with the same, and it's across all economic spectrums.
Right.
The why is fairly simple. It's a vibrant community. There are a lot of good people here. The problems here are similar to problems in every other community I've worked and lived in.
Okay.
The big difference here is there are a lot of people working to make it better.
Okay.
There are a lot of doubting Thomases, and that's almost generational, and you have to work with and around those individuals and not let them stop you.
Well, I'm not trying to pick on a community because
No.
I drive through this one on the way to and from Florida. But I mean, take a place like Bowling Green, Kentucky.
Sure.
I mean, how would you compare, contrast a Bowling Green, Kentucky with a Muncie,
So
Indiana?
I lived there for 7 years.
Yeah.
Bowling Green, when I was there, was largely a university town.
Okay.
The downtown was minuscule and dependent upon a bar and a restaurant
Oh,
and a couple of attorneys' offices because of the courthouse.
yeah.
Huge strip outside of town with every imaginable fast
Yeah.
food.
Right.
And the Corvette plant was there.
Right.
And that was kind of its claim to fame.
Yeah.
It's grown. It's now become almost a suburb of Nashville.
Oh.
When I was there 20 years ago, it was an hour to drive from Bowling Green
Right.
to Nashville. Now it takes 2 because of traffic
Right.
and the amount of construction that's
Yeah.
going on.
Huh. But when you talk about doubting Thomases and things like that, I mean, you didn't find the kind of community spirit there that you have found here?
Not to the level that it's here. And
Okay.
when I consulted all over the country
Right.
with mostly small and rural communities. There's a special level of pride and persistence here that doesn't exist in most other communities.
Probably part of the nation's Middletown label or something like that.
Perhaps the university obviously is a large part of that as well.
Yeah, but you had university in Bowling Green, too.
The university there was not as focused on the community, I think.
Oh, okay. Yeah, fair enough. When you talk about the root causes of much of this, and I want to go back to that, we're looking at a lot of this having been caused by the loss of well-paying union jobs. And so when you bandy about the figure that we use a lot, which is between 15 and 17,000 jobs just went, that has to have some effect on the clients that you're dealing with.
Sure.
And I guess that's a specific question. Is there any way that you can see, even though you've only been here a short period of time, that there has been a change in the impact that this economic downturn has had on the clients of Open Door?
So it's a multi-generational issue now. It's
Right.
been long enough. There are individuals that remember the good old days when, in their memory, Muncie was robust and
Right.
they were everybody was well paid,
Yeah.
had a car or two in their drive.
Yeah.
One of those that doesn't exist anymore.
Right.
A lot of people are stringing together one job or two jobs just to pay the bills,
Okay.
and it impacts behavioral health, mental health. It impacts physical health, and there are a lot of resources in the community that people aren't always aware of or don't always choose to take a part in.
Okay. Yeah, I mean, that's one of the things that we really have focused on, that when you pull that many, as they're now kind of called nationally, well-paying middle-class jobs, which were not just income, but also the fringe benefit programs.
Correct.
And so with something like the UAW, I mean, they had an incredibly good health care plan, pension plan, and things like that. And those are all gone, too.
Right.
Yeah.
Right. There are communities that Anderson has 2 hospitals
Sure.
because of the unions.
Yeah.
They could afford it. They paid well.
Yeah.
I think they're probably one of the few communities of that size in the country that still have 2 hospitals.
Mm-hmm.
I don't know how long that'll last.
Yeah, that's right. Have you had problems in finding staff, and has that changed over time? You know, finding the kind of expertise that you need to have to
So we go from the highly paid physicians, nurse practitioners,
Right.
highly educated, highly trained, high expectation. They're very difficult to recruit into town.
Okay.
It's a national competition.
Yeah.
if you read our newspapers,
Yeah.
you don't hear a lot of good things, or you don't read a lot of good things. So it can be really tough to get over that barrier. Once we get folks into town, they can see, feel, and
Right.
become part of the community.
Okay.
The university is a big help with some of the mid-level and lower level
Mm-hmm.
staff. We have a lot of staff here who's been with us for many, many years.
Right.
As the economy gets better, it's more and more difficult to hire
Mhm.
some of the lower paid staff because McDonald's suddenly pays well.
Yeah.
Um,
Right.
Most of our employees are here for adequate pay, but they believe in the mission.
Mm-hmm.
And they bend over backward to help the patient in any way they can. And that's what makes the organization work.
Yeah.
It's the mission-driven employees.
Well, given what your mission is, what kind of relationship do you have with IU Health, with the hospital?
Great.
Okay.
Two of our physicians here are actually contracted. They're employees of IU Health,
Okay.
and they work here, so we
Yeah.
pay them back for that. We refer to them for specialty care. They refer uninsured patients to us for continuity of care.
Okay.
We are in conversation weekly, if not daily sometimes, on particular healthcare issues or trends in the community and how can we work better together.
Yeah. Well, go into some of your other areas. How do you work with dental professionals? I mean, how do you find that?
So we have 9 operatories now.
Yeah.
We work full time. They're busy. We don't provide orthodontic work, so we refer out. So some of the orthodontists in the community will accept Medicaid. Many will not. We can help in the patients with a payment plan,
Mm-hmm.
and be very careful about what services they
Right.
get so that it's affordable.
How about mental health professionals?
There's a shortage of mental health professionals, not just in Muncie, but everywhere.
Mm-hmm.
Currently, it's about a year for our patients to get referred to a psychiatrist,
Mm-hmm.
unless they have commercial insurance or can pay cash on the barrel.
Yeah.
Not really acceptable,
Okay.
but that's reality at the moment.
Yeah.
We have, in the last several years, increased our behavioral health staff with psychologists and licensed social workers. And we work closely with Meridian Health, Cornerstone, the hospital, whatever we need to do to get our patients settled and improved. That's what we're going to
Yeah.
do.
What are the sources of your funding?
We get funding through billing of our patients or their insurance company, and that could be Medicaid, Medicare, commercial insurers. We also get federal funding to offset some of our expenses for taking care of the uninsured, or even for paying for services for those that are insured, but they can't afford the service or the copay.
Okay. Okay. Has that changed much in the last few years?
More restrictions, less money. Higher expectations, more reporting.
Yeah.
It's still a good program.
Yeah.
Like any federal program, there are lots of hoops to
Yeah.
jump through.
Well, that was my next question. How do you gain access to these funds? What's the
So you have to qualify.
Okay.
Your mission has to include, you have to be a nonprofit. You have to agree to see anybody regardless of their insurance status and ability to pay, country of origin, citizenship, et cetera. And we have to have a board that at least half of the board members are patients.
Where's that requirement come from?
That's HRSA, which is the Health Resources Service Administration, part of Health and Human Services.
Oh,
That's
okay.
one of the requirements.
Yeah.
The goal being we stay rooted in the community we serve.
Oh.
So to that end, it works very well.
Yeah.
We have 11 board members, 7 of them are patients.
And has that rule been in place for a long time?
I think for 40 years.
Oh my gosh, I didn't know that. Huh. You've touched on this a little bit, but I want to ask it specifically. How is Open Door Health Services impacted by local, state, and federal regulations?
Well, usually the more regulations there are, the more work there is.
Right.
It's a challenge over the last several years to stay on top of, much less ahead of, changing regulations and political winds. For the most part, whatever is required, we're going to do.
Okay.
We have staff that spends most of their time paying attention to what the latest, greatest federal regulations and changes are so that we can be compliant. There are, with more emphasis on behavioral health and opioid issues, there's more funding available to help us and others respond to that. Right now, it's mostly in treatment, not in prevention. We're working with other organizations on the prevention piece as well.
Have the regulations changed a lot, with the change in administrations and things of that nature?
They changed at the state level, they changed at the federal level. Some, it's kind of like a pendulum. It swings back and forth depending on who's there.
Yeah.
Without major changes, the emphasis might change. Like I said, the emphasis right now is on opioid and drug use and treatment.
Yeah.
Several years ago, it was all about dental. Years from now, it may be something else.
I mean, just listening to talk shows that I tune in every once in a while, regardless of the political spectrum, you hear a lot of people in Congress talk about, well, there's a lot of money available right now to work on the drug epidemic. I mean, that has indeed happened and filtered down to where you are?
It has not filtered down.
Okay.
It's being released. A lot of money is going to the states. The states have to figure out how to best use it. And there are a lot of people with ideas on what the best use is. So that's a constant battle at all levels of government.
Yeah. But do you have some personal views on that as to how it might best be used?
We need more treatment centers.
Okay.
We also need more money to prevent the need for more treatment centers. So if we could emphasize prevention more, I think that would pay off in the midterm and the long term. But we can't abandon those that currently have addiction issues.
Okay.
But it would be nice to prevent people with addiction issues.
Well, you hear a lot about the drug epidemic, not just focusing on Muncie. How does that play out in what you do? I mean, you can't go through a week here without talking to somebody, and I go to a couple discussion groups in town, and someone's always bringing up, well, there's the drug epidemic.
Sure.
I mean, I just wonder how that plays out with your client base.
So we have patients who have drug addiction issues. We have patients who are recovering, and they will always be recovering. They have to be extra careful about what medications they take.
Right.
It's a constant challenge. It drives up the complexity of care, and for the addicts and recovering addicts, it drives up their cost of living just to stay in a safe zone.
Right.
And the community doesn't have enough resources to help with that yet, but there are a lot of organizations trying to get there.
Well, in some of my other interviews, where it's come up is when you're trying to employ people and they can't pass a drug screen.
Sure.
So these are people that have difficulties in that area.
So there are people who are currently addicted. We won't say through fault of their own or not. They're just currently addicted. There are employers here in the area that will hire them anyway, and their employment is contingent upon them enrolling in and participating in a course to get them off.
Okay.
There are employers in other parts of the country that I've heard have stopped doing drug screens because it's the only way they can get employees.
Yeah.
That's kind of a scary venture, but that's what they felt.
Well, especially if
needed
you're living
to
in a state that's legalized marijuana.
Sure. Yeah.
Or a country.
Yep.
Yeah. Okay. Does Open Door have any specific kinds of connections with local faith communities?
We work through referrals with a lot of the faith-based community, back and forth. They might have a parishioner who suddenly doesn't have insurance or needs a particular type of service. So that is a constant back and forth. We actually locate some of our staff in offices at some of the churches to help with insurance enrollment. It's a pretty tight relationship. No silos there. We're all in the same field.
Okay. And as I know from studying the churches in the last couple of years, they're certainly aware of that too.
The churches are very active in fulfilling the needs of not just their parishioners, but the community.
Yeah, okay. The question we talked a little bit about before we began the formal part of our interview, if this country had some kind of Medicare for all or single payer plan or something resembling Canada or most of the industrialized world, would there still be a need for open door health services?
I have to think yes. There is no perfect system. And as long as there's a profit motive somewhere in the payment structure, those that are of higher need will have difficulty accessing the system. We tend to work with the individuals that have higher need and fewer resources. Canada, not quite as much as England. A lot of the European countries have essentially 3 levels of healthcare. It might be universal, but you've got the hospital and the health system for the poor, you've got the middle system, and then you've got the private hospitals and private concierge services that those with assets can afford. The assumption is they get better care. I don't know if that's true, but that's their assumption. So yeah, I think community health centers will continue to exist for that reason, and we do so much more than just provide health and health care. So there will always be a need for those types of organizations. My assumption is we'll evolve with the healthcare plans.
This is kind of out of left field, but I'll ask it anyway. If you could design a healthcare system for a nation like ours, what kind of healthcare system would it be?
The easiest way would be to take Medicare at 65 and kind of like your window blind, drag it down, pin it at 18 where the CHIP program stops, and connect them. Currently, we have a VA system, we have Social Security, we have Medicare, we have Medicaid, we have the prison system. That's a lot of federal and state government systems that don't necessarily work well together. If we could get them all working the same or very similarly, that would create a lot of efficiency, find a lot of money, and probably improve individuals' health.
Like what would the place be then for, as it's now styled, big pharma and the insurance industries, which are, of course, really significant in the way healthcare has evolved in this country? They'd still continue doing what they're doing?
I think they would have to change what they're doing. The political conversations about the good, the bad, there's obviously a place for them, but they would have to change how they do business. And that's okay.
Well, I'm just, you have expertise in this area that I don't have, and I just wonder, because you're, at the grassroots of this, do you really think this is beginning to change, this whole debate that is now seeming to have much more energy to it than it did, say, 10 years ago?
The economics of it are requiring the conversation. The fact that we're the only industrialized country without a national health care plan is curious. That doesn't mean it has to be better or worse, but it's curious. We're as decentralized as any other industrialized country, which is what makes it difficult. The states tend to be the experimenters. There are states that make some things work well and states that struggle. So if we could pull all the good stuff together and nationalize it, we might have something.
Good note to end on. Those are all the formal questions I have, but I want to give you an opportunity to add anything you wish about your observations and the time you've been here, and again, perhaps comparing and contrasting them with other places you've been.
So I've obviously most of my time's on the East Coast, although it's not on the coast, East. When I consulted a lot in Texas and Arkansas, Alaska, lots of small communities. Muncie's unique. I mean, it's a larger community. It feels small. It's the energy that's here is really good, positive energy. I kind of describe it as there are lots of cogs that are moving in the right direction. There's a lot of space and there's a gap in between the cogs. As the cogs grow and get closer together, there will be some gnashing of teeth, literally and figuratively. But once they get in gear, things will really take off. And I think most people can see it and feel it.
Thank you very much for your interview.
Sure. Happy to help.